Hello. So today I've seen a patient who has background of aplastic anemia, and he has come in with aplastic crisis. He was intubated. His HB was 22 when he came in, platelets low, neutrophils below. So the pancytopenia picture. He has had bone marrow transplant earlier, a couple of months back, and that failed. So he also developed mixed autoimmune hemolytic anemia picture, and he was refractory to having steroids, having immunoglobulins given. So he was started on monoclonal antibodies, which was rituximab and eculizumab, and he was responsive to it. Today, we've discussed with the hematologist to see if we can restart his regular medications. So earlier, we were told not to give the colony stimulating factor, which we would usually give if the neutrophils are low to prevent neutropenic sepsis and to help boost the turnover. But in this case, because I believe it's a crisis phase, you wouldn't give that because it wouldn't stimulate the bone marrow to produce enough neutrophils. But we went to look at his background medication. He is having acyclovir, cotramoxazole, also having penicillin V, and then supplements like folic acid, cyanocobalamin, then L-thrombopag, that is to stimulate platelet growth, and then darbepoetin, that is to stimulate the red cell production. So he was having all of this in the as a prophylactic and treatment. I've ranked them to discuss if we can restart them. Just waiting to hear back from them. I will want to study about when do we start patients on this prophylactic medication, because I understand that they're immunosuppressed because their WBC count is low and they're more prone for infections. What is a cutoff when we start them? And also because he had this graft transplant, I believe we want him to be immunosuppressed. We're not giving him any immunosuppressant, if you know what I mean. We're giving mostly antimicrobials to prevent infection. It's not graft versus host kind of reaction. It's more about preventing infections. Um, and he's also grown sputum positive for Aspergillus fumigatus. He had already had this infection previously and was treated with antifungals before, posaconazole, I believe. We've sent an endobronchial sample. So yesterday I just learned that there are two kinds of endobronchial samples. One is non-directed endobronchial samples, and the other is directed endobronchial samples. So non-directed means where it's a blind procedure where there is an inline suction catheter, which you would put into the ET tube and suction as you would regularly do for caring of the ET tube. But then you would take the samples and send it to testing. That directed would be when you put in a bronchoscope to visualize that and then take samples that will be detected. So he had non-directed before he was extubated. He was neurologically fine, so now he's extubated. He's just on a face mask. So the other tests which we did for him were to look for parvovirus, because that is notorious to cause this kind of bone marrow suppression. Then also checked for IgRA for tuberculosis, and cytomegalovirus, and also for EBV screen. And I'll let you know how it goes with him.